Good evening, everyone, and welcome to another session of our Veterinary Call live Q&A. I'm very glad to have so many of you. I've just did a quick count of how many countries all of you are watching, and it's about 18. So going from Brazil to even Russia or Thailand and Taiwan. Fantastic crowd again tonight, very international. Similar format as we've been doing for the last few weeks. We have a guest tonight, which is Shannon Holmes. I will tell you a little bit more about her in a minute. Simon will ask Shannon a few questions about a topic of expertise of Shannon. She will illustrate that with a number of slides. And at the end of her presentation, I will invite you to put comments so I can ask specific questions from you to Shannon, but feel free to put your comment during a presentation as well. As I say, I'm delighted to have tonight our guest speaker, Shannon Holmes. Shannon is a radiology diplomate from the ACDR. Shannon works in the US. She is the founder of a teleradiology company called Axis in the US. She is also a part-time radiologist at the Animal Medical Center, and she's the radiologist for Animal Scan ALC as well. But beside all that, if you had a chance to follow us and to attend our online neurology symposium last October, you will have had a chance to listen to Shannon talking about spinal disease and realize she's also a fantastic speaker and an excellent teacher as well. So we're very glad to have Shannon again tonight. And Simon will be taking over from now, ask a number of questions on the subject of imaging of brain trauma before I will come back to you to ask a number of questions that you may have put on the comment box. Simon, over to you, and thanks a lot again, Shannon, for being with us.
Thank you.
Great. Thank you, Laurent. And thanks to everyone for tuning in from all over the world. Shannon does speak 16 languages, apparently, so she's happy to translate this talk for you. That's good. Laurent, no beer tonight? What's going on? Nothing?
No, I've actually gone doing a month off.
Okay, so, I'll call you in 2 days then. Let's see how that goes.
Cutting on carb, and the pint is empty, I'm afraid. So I want to have my beach body back.
That came across not as beach, but as if that's how you have your body. No problems. All right. Okay, Shannon, thank you so much for turning up. As you know, our theme here is to have people that know a lot more than us about these subjects. And so we are honored to have you here, MRI being your major specialty. So we want to get us started with this by talking about kind of the basics, as there's a lot of people here in general practice, and the big thing that they would want to know right out of the gates is if they have a patient with brain trauma, some suggestion that the head's involved. Do skull radiographs have an imaging potential for traumatic brain injury? Should we be doing those?
So I think that skull radiographs, for me personally, once there's neurologic signs, I don't know that they have a huge amount of value just because they don't always tell us what we need to know about the neurologic system. Let me just jump ahead to a couple slides.
Sorry, you want me to come out of the...
Yeah, I'll share my screen now.
No problem.
If that's okay.
Let me know. Do you want to go on full screen, Shannon?
I think can everyone see this? This way I can kind of jump around a bit better.
Yeah, okay. You can see that pretty well.
So, like I tend to think when the patients come in, and they come in differently to referral practices like general practice veterinarians versus specialty practices, there's an inclination to jump to imaging because that's kind of a comfort zone for a lot of people. It helps us figure a lot of things out. And we kind of have, a range of modalities that are available. Generally, everyone has access to radiographs. And I think historically, those have been our first line kind of modality that we use to go to. But in looking at it from a clinical point of view, I think imaging kind of comes in after everyone's done their assessments, because what has historically been kind of more reliable, at least in treating the patients and everything like that, is that the MGCS, or the Modified Glasgow Coma Score, has been used as and should be the main consideration in whatever you're going to do imaging wise, whether it is radiographs or whether it's advanced imaging. Because I think the thing that people always think about with imaging is, we're going to get the answer and we're going to know what to do. And I never think you should do the imaging unless it's going to change what you're going to do. The other thing about imaging, especially with these patients or any traumatized patient, is that radiology is not a great environment for unstable patients. So there's always been a long-term, it's kind of said in jest, but it's actually very truthful, is that no patient should ever die in radiology. And the reason we all believe that is that if they get to radiology and they're so unstable that something happens, that they do deteriorate really fast in radiology, none of the radiology suites, CT suites or MR suites, are set up for critically ill patients. And so, you just don't have what you have in an ICU to deal with these patients. So I generally will trepidatiously go into imaging patients with traumatic brain injuries that are unstable, just because I don't think we have the ability to kind of get what we need from those imaging modalities as versus what we know about them from our physical exam and our neurologic exam, and the treatments we can start initially that are probably better as far as treating the patient, because you're trying to reverse a lot of the secondary effects of the trauma to start with. And imaging isn't really going to change, in my experience, although I have only actually laid hands on patients for a year of my career. But I think that you have to think about, what the patient's doing before you head to imaging. And then when you head to imaging, to go back to Simon's question, I think radiographs can have a role, because radiographs have, they're ubiquitously available and they're not super expensive relative to other imaging modalities. So it can aid in having discussions with clients when you're considering radiographs, because sometimes radiographs can be an endpoint for people and it's a more economical endpoint. The only challenge, I think, when you're dealing with radiographs is that they may not give the full clinical picture. And we've seen cases from CT and MR now that have made recoveries from conditions that we wouldn't have thought possible based on radiographs. So there's that caveat. It's a little bit of, what your outcome goal is and how far the owners are willing to go, because after radiographs, everything becomes a lot more expensive. It involves referral to a specialty hospital in most cases, to a neurologist, and then everything imaging wise after radiographs is much more expensive. So I think when you're talking to clients about that, they're somewhat traumatized as well, but at the end of the day, they have to, they have to make the decisions that they can live with. So just to kind of, the other thing I think about radiographs is that they're not easily performed on awake animals, at least not good radiographs. The other thing too is that whatever restraint mechanism you're using to kind of get the animal to stay on the table for the exam may apply pressure to the skull, which always makes me a little nervous with patients that have traumatic brain injuries. So I think those are the things that I consider. Obviously, if the patient's obtunded, it is very easy to take radiographs. And then one other advantage that I didn't list is that you can send them out and get stat reports if you're unsure about interpreting the radiographs, because there's so many teleradiology groups now. And I think that the value of that is that people don't do skull radiographs routinely, and it is a very complex anatomy to interpret. So I think that, you know, if you're used to kind of looking at the uniform opacity of the calvarial vault and you can check its integrity, you know, that's good. But, you know, not everyone is going to pick up on the lucency, that's the bite wound, that's the depression fracture into the calvarial vault and affecting the brain in this case. And it's just because you don't look at radiographs. People do thorax, they do abdomen very routinely. Skulls are really becoming a thing of the past in the age of CT and MRI.
Excellent start. Thanks for getting us going. And using the word trepidatiously in there as well. While I'm asking the second question, I'd like you to translate that into the 16 languages. But good.
Maybe later.
Good start. Well, having said that really the neurological exam, the systemic evaluation of the patient obviously takes a priority in these cases. If you're faced with an acute traumatic brain injury, should CT or MRI then be selected if you are going to go with an advanced imaging approach?
So I generally, it depends a little bit on the institution I'm working in and kind of the logistics of how you can move patients through the hospital. In general, and this is where it can become quite expensive. In general, I'm going to start with CT. And I'll just go to my CT little slide here. So I'm going to start with CT most of the time because it's very quick. I can get what is effectively a 3D radiograph. So it's just like radiographs in that it's good for bone. It's okay for soft tissue. We missed a lot of brain lesions before the advent of MRI because it's not great for soft tissue. But you can definitely see fractures, and it gives you an idea of how depressed they are. If you do need to embark on neurologic surgery immediately in the emergent scenario, there's lots of things you can do after the animals left the CTC suite. So the initial exam may take a minute to do a skull exam. If you have a multi-detector CT, then it's seconds. And so therefore it's very fast, faster than radiographs. A lot of places have gone to doing whole body CTs in polytrauma cases, in which case you get the brain as well. So I think that's the advantage of it, is you can screen an entire body in under 2 minutes. And then you can, after the patient leaves the CT suite, you can do reconstructions where you can look at all the bones in different angles and orientations. So I kind of always think the sagittal is kind of like a lateral radiograph and the dorsal is kind of like the DV, but we mostly look at the transverse. And so I think more recently, in the age of 3D printing, we've done a lot more CTs of brains where they're actually building implants to patch areas of fractures. They've done that in horses as well. So I think for a test that's shorter than it takes to position the animal on the table, CT is the first line diagnostic in a referral setting in my mind. It is in humans as well. It's just much easier. The other advantage is that because it's so fast and because you can do these reconstructions, you don't necessarily have to worry about the position of the patient because you can fix any positioning errors with the reconstruction. So you can then do awake animals, you can do semi-sedated animals. You don't have to do anesthetized CTs because when you're acquiring the image in seconds, it's almost as fast as a radiograph. The other thing too is that it does give you some soft tissue information that can send you immediately to surgery. What is most notorious about CT and why it's used probably ubiquitously as a first-line diagnostic for head trauma is because it can show you lesions that require decompression of the brain. So here we have a subdural hematoma, and we know that because of the value of the signal in that area, which matches what we expect for hemorrhage. In this case, we have an edema pocket, but having the same effect on the brain. So the outcome for the neurosurgeon is the same, just what we're expecting when we get in there is slightly different. So I think with CT, kind of how I think about it is I can do it on virtually any patient in any condition because it is so fast. It's excellent for bone. It's okay for soft tissue. Unfortunately, the brain is mostly soft tissue, and a lot of the things that have been associated in humans with prognosis do not show up very well on CT. So it tends to be the acute phase imaging modality, but not necessarily the chronic phase imaging modality.
Okay, great. And yeah, good point that you brought up just in there about the fact that now they can be used to help with 3D printing and reconstruction. We had Fred Winninger on a few weeks ago talking about that and how his company is able to help out some of these patients that are a bit too complex for us normally. So that's also a good point of doing CT. This next question may be a bit of an overlap with where you've just been, but it's what is the main advantages and disadvantages of CT in imaging potential traumatic brain injuries? If it's an overlap and you've already said it,
sure,
we can move on.
I think it's I think the one thing to talk about, though, maybe in addition to what I had mentioned, it is so fast. It takes longer to position the patient either in radiology or in CT than it takes to acquire the images. So from that point of view, it's a huge benefit to the patient because you're imaging it so fast, but you're getting so much more information. It is more expensive than radiographs, but I think from a decision-making process of the patient coming into the hospital and what do we need to do? Say we've tried, mannitol and things like that. We just need to make sure that we're not missing something. CT is a very quick and fast test to kind of get you in and out of radiology and back into ICU and stabilizing the patient, but also making sure you're not missing anything that needs emergent surgery.
Right. Excellent. And so now moving on to MRI, one question that people ask, as you brought up the CT, one of the advantages of CT is you don't have to use anesthesia in some patients. Is that the case with MRI? Can MRI be performed without anesthesia in these cases?
Yes, I have done MRIs on attendant patients. I've done them on obviously comatose patients, and I've even done them on heavily sedated patients. I do modify the MRI protocol in those. So a routine MRI for a brain tumor is about 45 minutes. There are protocols that are built, and they're on virtually every MRI when you purchase them because we buy human MRIs, and they use these protocols quite routinely. But within their architecture, they will have built a traumatic brain MRI protocol, which is about 5 minutes in total. And so it's not as quick as the CT, but it's certainly quick because normally that would be one sequence of all the sequences we get of an MRI, and you're getting all the soft tissue information that MRI provides with that protocol. So they've kind of chosen the sequences that give us the most information about what we need to treat the brain and the brain injury, and we can acquire it in 5 minutes.
Right.
Not routinely done in veterinary practice. For example, when I was at Georgia with you for 7 years, we never did a traumatic brain injury protocol. So it just depends on whether they get there. We did more CTs of traumatic brain injuries as a first line for sure, and then probably moved in the more chronic phase to the routine brain because they were more stable and we were trying to figure out what we were going to do next.
Yeah, and that leads into that next question is when then should MRI be selected? When is the advantageous time for MRI to be used in a traumatic brain injury case?
So I think from my experience, it's often a discussion between the neurologists often, in my experience, have decided when the MRIs happen more so than when they come to radiology. I think that when I see them move from CT to MRI is when they're not responding appropriately. You're kind of out of that acute phase of managing the patient. So kind of they've been in the hospital maybe a day, they're not responding appropriately. They may have even had a CT ahead of time. Those places do exist. I generally try to encourage wherever I work to have kind of a traumatic pricing where it isn't so cost prohibitive for owners to get both a CT and an MRI, because in my mind, they're truly complementary. You may be able to get away with just the CT, but a lot of cases do end up needing to have the MRI subsequently. It also allows you to monitor the patient. So I can show you a case here of a cat that was a rescue cat. We did the CT first, had quite extensive parenchymal changes where these hypoattenuating or gray areas are. The ventricles seemed large, and it was a young cat, so we weren't sure if there was some, congenital abnormality. And then 2 weeks later, we MR'd the brain, and what we could see was what we thought was maybe actual parenchymal loss was more changes in the actual parenchyma, whether it's edema, ischemia from the traumatic brain injury. But it did also look like he had some congenital disease because he had some hydrocephalus that was beyond what we would expect in that age patient. So I think that, it moves us from knowing or equivocating or not being sure on the CT to being more sure, and also being able to predict that what we know from MRIs is when the parenchyma is hyperintense, like it is on this FLAIR image, those areas tend to become damaged. And so if you have substantial parenchymal edema or hyperintensity, you can have substantial parenchymal loss, which can translate obviously into, severe neurodeficits.
All right. Excellent. You made a great point early on in saying that we need to be doing tests for a reason. Like, what are we getting out of these tests? So think about that before we do them. So we come to kind of the last question here, and that is, what does CT and MRI tell you about the prognosis in these patients?
So curiously, I had not seen this beforehand, but there's this paper with Dr. Platt as an author.
Pink arrow, nice.
Somehow missed that. Anyway, I think that there has been a lot more MRIs done on TBIs of dogs and cats and even horses. And I think that the main things are what I was talking about is there's certain abnormalities that are just inherently easy to see on MRI, and they've been associated with things like whether they're going to have seizure issues afterwards. And so the parenchymal changes that I talked about in the last case, they showed that they correlated with the coma score. So what we've been using serially in ICU with the MDCS correlates with the MRI and allows us to predict if they're going to have an increased risk of seizures, which obviously seizures are suboptimal in managing traumatic brain injuries and can cause further damage to the brain parenchyma. They also found that things like fractures, which would be more easily seen on CT, I think that we have to move away from the idea that MRI is bad at bone. In the early days of MRI, everyone would say that, and I think I even did myself. I don't think that anymore. I think that the sequences and the technology is such now that we're very good at seeing skull fractures, at least clinically significant skull fractures. especially those that are depressed, because those are the ones that are going to compromise the brain parenchyma. And so those are easily seen with MRI in the majority of cases. I can show you a small one that was seen on CT. This dog had a depression fracture of occipital bone, and we could see the displacement of the fracture fragment into the calvarium. But what we couldn't see with CT was all the parenchymal change, because it's not causing as much swelling of the tissue or displacement of the tissue. And then we can also see that there's hemorrhage, and hemorrhage in parenchyma is not great for it as well. So I think that you can have a range of things that you can find that have impact on the condition of the patient, or how well you're going to be able to recover the brain before it's too damaged to be recovered. And obviously, once your brain starts exiting the calvarial vault, those are also super bad for it.
Right. Excellent little summary there on that point. Thanks very much for that. So now we're out of questions here. So I was going to hand you over to Laurent to see what our viewers have come up with in terms of questions.
Yeah, so far we got a couple of questions. I just wanted to reiterate, I think, it's very important from a clinician point of view that, you only do a test if you look at the outcome of the test. And, with head trauma, it's very important to realize that with regard to therapy, the indication for surgical management of head trauma are very few. I think, in 23 years, I don't know how many salmon have been in that situation, probably at 5 dogs requiring surgery, so not very often. A lot of clinicians often want to know when the dog is, comatose, how long to give. And unfortunately, imaging modality hasn't offered yet the opportunity to tell us it's over. They may give you sometime the extreme case, but there is always gray area. And, unfortunately, the MRI is not going to tell us more, on that front. And that's the also a very important message. Shannon, there was a question about, can you elaborate a little bit more on what sequence are in traumatic brain protocol? You mentioned that for the MRI.
So I follow the human protocol, basically because I pull it off the human magnet. I don't reinvent the wheel. The challenge is it's similar to the sequences we use in a routine protocol, but they're just a lot lower resolution. So you would run a T2 flare, you would run a T2 and a T1, generally without contrast, because you're trying to be fast and you're trying to not disrupt the hemodynamic system. And so you can do those when you're doing the resolution, when you're changing the resolution, that actually is what speeds up the sequence a lot, because you can do thicker slices at lower resolution. And therefore, even though the brain in a dog or cat is quite small, your 5-minute T2 sequence that you run routinely can become a minute sequence through just making slices thicker and reducing the resolution. Because what you're really interested in with the traumatic protocol is the signal intensity characteristics that tell you about the pathologic change. You're not as interested in finding very small lesions. You just want to know kind of a global quick picture. And so you can, some protocols will include a sequence that's sensitive for hemorrhage. It just depends on, obviously imaging is always a trade-off of time. So you can run as much as you want, but in the 5 minutes, I tend to do those 3 sequences plus or minus a sequence for hemorrhage detection.
Very good. That's more a question for Simon. Is trephination ever appropriate in the ER without being able to do this modality?
I would have to say that I can't answer that clinically. We've just not looked at doing that.
I think in human, it's actually at a quick look. Is in the US, you want to use your license if you are doing trephination, but a lot of neurosurgeons will not do them. So the idea of making a hole to release the pressure as if it was a pressure cooker, it doesn't really work like that. So the answer to that is personally, I don't think it would be appropriate.
Yeah, and I also feel like in the odd times that we've done a craniectomy in cases, not to relieve pressure, but in cases that have a high intracranial pressure, if you don't make a large window, then that brain could certainly herniate out, mushroom out, and then all of a sudden become extremely ischemic. So a little bit nervous about doing it, not knowing what's underneath, where we're going. And also, I would say that if I were going to do something to reduce intracranial pressure, it would probably be a much larger window than that.
Absolutely.
I have been, on that kind of side as well, I have been asked to do ultrasounds through fractures to look for whether there's herniation through the fracture. And I think we all trust ultrasound a lot. I have done it because I've been asked to do it. And the big trick is you really just, ultrasound's all about contact and pressure, which you cannot apply to a brain or a fracture. And so you're basically having to image through as much gel as you can put on and kind of hover the probe. And having compared the ultrasound results to the cross-sectional like CT or MR results, it's very unrewarding to attempt ultrasound of these dogs as well. And I always am fearful that I'm going to press down and increase the pressure when I do them. So I've only done a handful of them. But I think people jump to ultrasound sometimes because there's an ultrasound sitting in a lot of emergency ICUs now as well. And so I think you just have to be super, super careful and realize that you're not getting a good look at it and you're probably going to underestimate the amount of damage.
We'll ask the last question to Shannon. If you have any more questions, please feel free to post it. It's your last chance. Another one is, what is your opinion about the prognostic value of CT in dog with head trauma?
What is my
What is your opinion about the prognostic value of CT in dogs with head trauma?
I think there hasn't been a lot in veterinary imaging looking at prognostic factors related to imaging, whether it's CT or MRI. There's a handful in both. If you look at the human papers, what they found was that in general, their serial monitoring using the coma score was far better prognostically than any imaging, whether it was CT or MRI, which as a radiologist is obviously a little bit disappointing for me. But it's realistic because I think that these patients don't always do well. If they're unstable, I'm probably going to go to CT first just because it is so fast. But like Laurent said, the number of traumatic brain CTs that I've done in my career is very small compared to everything else. So they just don't tend to get into imaging, even for radiographs, a lot. And then I think that you have to have the conversation about how much money they're willing to spend, because you can start at radiographs, which would be about $150 for a skull scan in the States, versus an MRI that's gonna, even the 5-minute protocol, it's hard to get administration not to charge their routine brain study, which is around $1,000. So it's very expensive, the imaging part, and I think it's more important to spend the money on treating the patients in some of those scenarios, because owners only have so much money in a lot of cases.
Yeah, and I think it's just to add to that, and it sort of echoes what Laurent said about can you look and say enough is enough, like this patient won't recover, and we can't. And so although there are some prognostic scales out there for both CT and MRI, they can't be used in isolation. We would never look at a CT or MRI and say, all right, your dog must be euthanized. I mean, we certainly can say, in addition to the neuro exam and systemic changes, prognosis seems to be poor. But that's where some of these scales kind of fall down, is that looked at in isolation, they're perhaps not the most reliable things.
Very good. There's no more question. That will be the end for this live. Shannon, I can only say a big thank you again for being with us. Just to remind everyone, Shannon run, Axis, which is a teleradiology company in the US. So if you, US based or even South America, feel free to make contact with Shannon. Shannon, you can find a detail, on Google without any problem. Simon, over to you, and Shannon, thanks a lot again for your time.
Thank you.
Yep. Yeah, thanks, Laurent, and yeah, thanks, Shannon. Great to have you. You've wrapped up our series, our plague isolation interview series. Who knows how long this will go on? We may have to come back, bring it back with another series. But thanks very much for wrapping that up in style and getting to the bottom of a few of those points with imaging. Thanks for giving up some of your day here. I know you're probably just getting over Canada Day. And so it might have been a tough call to start talking science, but all right. But thanks very much. Really appreciate it.
Have a good day. Bye-bye, everyone. Bye-bye.
Bye.
All right.